everybody here. Good afternoon, everybody here present in the aula and those who are following us by live stream. Welcome, everybody here in this academic session, which I open now, in which Dr. Cecilia Tetta will defend her academic thesis titled Lung Metastases from Soft Tissue Sarcoma, and she will defend that thesis, as I said, in public. As you have noticed, and which is quite evident for evident reasons, we will do everything in English today, the questioning, the ceremony, etc. So, okay for you?
English, please.
Yes, okay. Then, before we start as a committee the questioning, the opposition as we call it, the candidate, Cecilia Tetta, will give a short presentation about the research she performed and give an overview of the most important findings and conclusions. I ask you to start this presentation now and wish you the coming hour lots of success and inspiration.
Thank you, Honorable Prorector and Honorable members of the Corona. Thank you for being here today. It's a great honor for me to present you my thesis. My thesis is called Lung Metastases from Soft Tissue Sarcoma. Soft tissue sarcoma are cancer. So, a brief premise, about what cancer is. Cancer is not a single disease, but is a group of diseases with some common characteristics. The term cancer refers to a pathological condition characterized by the uncontrolled proliferation of abnormal cells that have the ability to invade the nearby tissues. They also have the ability to migrate through blood and lymphatic routes from the organ of origin and colonize other areas of the organism. These other areas are called metastases. Soft tissue sarcoma are a rare group of cancer with an incidence of 5 or 4 per 100,000 per year, and they are cancers of mesenchymal origin, so they may develop in the connective and supporting tissue of our body. That means that they may develop in muscle, blood vessels, joint tissue, nerves, and fat and deep skin tissue. They can grow almost everywhere in our body: head, neck, trunk, abdomen, upper limbs, and lower limbs. The histological classification of these diseases encompasses more than 50 different histotypes, categorized according to their line of differentiation. So this is just an overview to show you how complex this classification is. Soft tissue sarcoma grading expresses the grade of malignancy of this entity and is based on the French Federation Cancer Center system, which evaluates 3 parameters: the tumor differentiation, the mitotic count, and the tumor necrosis. A score is attributed to each of these parameters, and the grade is the sum of these scores. Soft tissue sarcoma metastasis may occur in up to 50% of patients with soft tissue sarcoma, and the most common site of metastasis is the lung. So this thesis deals specifically with the lung metastasis from soft tissue sarcoma and investigates various aspects of this disease, from the diagnosis to treatments, including surgical and non-surgical treatments, prognostic factors with an eye on future perspectives. The second chapter of this thesis is focused on the diagnosis. So early detection of lung metastasis in patients with soft tissue sarcoma is critical for choosing the best treatment of these patients. The gold standard technique employed for the diagnosis of lung metastasis is computed tomography. So in this study, we aimed to identify CT features and clinical data able to predict nodule malignancy. So we built 3 models, the first including only clinical data, the second including CT features, and the third model including both. And this last model was the one who reached the highest performance and the highest predictive value in detecting malignant nodules. Indeed, after having identified the clinical features and CT features, we showed that the combination of both increased the risk of malignancy up to 28-fold, as we can see in the last line of this interaction analysis, when a new onset nodule is associated with the surgical margins R2. These surgical margins are referred to the primary tumor resection and means that the margins of the resection of the primary tumor are macroscopically involved by cancer cells. In the third chapter of the thesis, the focus was on surgery. So surgery is the mainstay treatment for these patients when a complete resection is predicted. So in this study, we aimed to identify predictors of lung metastasis recurrence and of lung metastasis-specific mortality in patients undergoing lung metastasectomy with soft tissue sarcoma, of course. Our results show that lung recurrence occurred in about 76% of patients, and predictors of this outcome were a particular subtype of soft tissue sarcoma, that is the malignant peripheral nerve sheath tumor, along with the disease-free interval, that is the interval of time between the resection of the primary tumor and the first diagnosed lung metastasis. Also, the lung metastasis size was a predictor of lung recurrence. Deaths from lung metastasis occurred in up 50% of patients. Moreover, another 30% of patients died for lung metastasis and metastasis in other side. That means that 80% of patients died with lung metastasis. Predictors of death from lung metastasis were 2 subtypes that are synovial sarcoma and myxofibrosarcoma, along with the disease-free interval and primary tumor size. Moreover, patients who underwent chemotherapy after lung metastasectomy showed an increased risk of death. In the 4th chapter of this thesis, and in the 5th chapter, as we will see in a few minutes, we explored non-surgical approaches to treat these diseases. And in particular, in chapter 4, we compared through a meta-analysis outcomes of stereotactic body radiation therapy and surgery, as BRT is traditionally reserved for patients unsuited for surgery, and the aim of this study was to identify if it may be employed beyond these traditional indications, and in which cases. Our results show that overall death rate in metastasectomy was higher, with comparable mean overall survival and comparable rate without disease, while survival rate with disease was in favor of stereotactic body radiation therapy. In the 5th chapter of this thesis, we performed a literature review to compare outcomes of stereotactic body radiation therapy and radiofrequency ablation, that is another non-surgical approach to treat this disease. And we aimed to evaluate the efficacy and the safety of both. Our results show a high local control for both procedures with low rate of severe complications. In the 6th chapter of this thesis, we explored the role of chemotherapy in a particular subtype of soft tissue sarcoma, that is the synovial sarcoma, which is considered relatively chemosensitive with a high proclivity to metastasize to the lung. our results show that freedom from synovial sarcoma-specific mortality was lower in patients undergoing chemotherapy, adjuvant chemotherapy after lung metastasectomy, and this result was strengthened by female sex, older age, short DFI, and large primary tumor size. Finally, in the last chapter, we tried to explore a new field for the diagnosis of lung metastases, since the applications of machine learning are increasingly expanding in the field of diagnosis and treatment. And so we aimed to develop a prediction model for lung metastases from soft tissue sarcoma following lung metastasectomy, employing machine learning algorithms. Our results was the building of this prediction model, and the building of this model was divided in phases. In the first phase, the preprocessing phase, we divided our data set into groups. The first group was the test group and the training set group, and the other group was the hold-out set group. The first group was needed to feed the algorithm, and the second to test the model. The machine learning process was further divided in 3 phases. The first phase, the selection clinical features, and the results is shown on the top figure on the left, where the features are put in decreasing order of importance for the building of the model. After this phase, we analyzed our model and we chose the value, the number of variables with the highest performance, and this value is called hyperparameter, and for our model was fixed at number 11. Finally, we tested our model with all outset, and as we can see in the figure below, the 2 ROC curve of the model and the test group were close. That means that our model was performant and reliable. So from the key points of this thesis, I would like to conclude that in this type of cancers, of conditions, more than in other entities, is crucial a multidisciplinary team, an ultra-specialized multidisciplinary team in referral center, which includes not only radiologists, surgeons, oncologists, pathologists, and radiotherapists, but are also engineers specialized in novel technologies. And this is crucial for this entity since their rarity, their aggressiveness, and their highly tendency to metastasize. So thank you for your kind attention.
Thank you for this clear overview, which gives a good impression of what you have investigated and what the discussion will be about. You have not used all your time, but you're not so concise that we have left much more minutes for the discussion. So stick to your schedule, which we discussed before, and then everything will go fine. So now we started the opposition, the questioning. That is done by Professor Van Zwam. He is an interventional radiologist at his university, and he was a member of the Manuscript Assessment Committee. Professor Van Zwam.
Thank you, Mr. Prorector. And dear candidate, let me first compliment you with this beautiful thesis, beautiful book, and I extend my compliments to the whole team, of course. It's a very nice, concise book. It's far out of my topic of interest, and therefore I learned a lot by reading it. And I was also a bit surprised by the image at the front page, which there are 3 doctors and 1 is smoking. So I immediately thought, so smoking probably has something to do with the predictive...
Sorry, could you...
It is 3 doctors on the front page. One of them is smoking.
Thank you.
So I immediately thought that smoking maybe influences the metastasis. We know it influences lung tumors, but also metastasis. I didn't see it in your thesis, but do you know if there's any association of smoking with these metastases?
Thank you, highly esteemed opponent, for your nice words and for your observation. Now, the figure was chosen from a picture I like, and I chose this photo because it depicts 3 doctors, and in my idea, these were the figures of the multidisciplinary team. I didn't notice any association between smoke. No, I think the smoke, of course, is more related to primary lung cancer, but not in these cases and not in these particular diseases which have other risk factors than smoke.
Yeah, I thought so when I read the book afterwards. So, no, and I want to ask a few things, and I would go to chapter 4, and on page 90, you write in outcomes that the median disease-free interval defined from the date of primary tumor resection and the first metastasectomy or radiotherapy ranged from, etc., etc. And so I thought, and that's more lack of knowledge on my side. So this disease-free interval is a baseline characteristic of this cohort. It's not an outcome of the treatment, is it?
You mean the table, page 90, sorry?
Yeah. Well, yeah, you write the median disease-free interval defined from the date of primary tumor resection and the first, treatment, metastasectomy or SRBT, so radiotherapy. But is this disease-free interval a baseline characteristic of those 2 groups or an outcome of the treatment?
No, thank you, sorry. This was not a baseline characteristic, but we observed, reading the articles, that most patients had already been treated with surgery. This is not a baseline characteristic, but it happens frequently in relation to the traditional indications to SBRT and other non-surgical approaches. That is when the clinical patient status contraindicates surgery.
But it's not an outcome measure of those 2 treatments, is it? Because then what is the definition of this disease-free interval? What is the end of that interval? Is that imaging or clinical?
Maybe I'm looking at the wrong page. Sorry, page?
Page 90.
90.
And outcomes. Directly under outcomes.
Yes, the main characteristic, yes. Oh, yes, the disease-free interval is should be always reported in articles, since it has been proven to affect survival and lung metastasis recurrence. So this is a crucial point to highlight, especially when a lung metastasis has occurred.
Okay, so it defines for the 2 groups a bit the severity of the metastasis. If the disease-free interval is longer, that means that it is more favorable?
I try to explain in a simple way. The disease-free interval expresses the pace of growth of these tumors. So a short disease-free interval means they grow quickly and they spread quickly.
Then I'm correct, that is a characteristic of the tumor, so not an outcome of the treatment.
Gives an idea in this.
And another outcome you report is the cumulative mortality or death rate. But what I saw between the 2 groups, there's a big difference in the period of follow-up. And I would think if you have cumulative death rate, then the longer you wait, the higher this death rate. So does it say anything about the cohorts, or does it say anything about the length of your follow-up?
The length of follow-up, in my opinion, influenced the results of these studies. And the length of follow-up may explain why we had a lower survival in patients undergoing metastasectomy, since in the articles we explored the results after surgery, the follow-up was longer than in articles we explored as BRT results. And in SBRT articles, in very few articles, the follow-up was longer than 2 years.
Yeah.
Because they mostly observed the local response to treatment.
Yeah, because here you say the cumulative death rate, but in the next chapter you use the 2 years death rate, which is more logical
yes,
that
because
you
I had
compare
to,
those two groups.
yes, because I had to find a way to show the results in an homogeneous way. So some articles reported their results in 1 year, 2 years, other in 3 years, not longer than 3 years, some in 5 years. So I found the 2 years of local control measure that was reported in almost all articles. Yes.
Yeah, so those death rates and follow-up, that brings me in fact to the last and most important question maybe. You also write that we can compare those two treatments now. You do the same in chapter 5. You compare two treatments, but you say we don't know. It's still not clear, you write on page 101, it's still not clear to which extent the treatment of these metastases influences a patient's survival at all. I mean, so if you compare it with no treatment, is there any benefit? So, especially in this time of sensible healthcare, well, what do you think? Is it sensible to treat those patients? Do you know what the difference is in general with the natural history if you don't treat them? And what the costs are? In fact, there are two questions important for this topic.
Thank you. This is a very crucial point. I think that for these patients we have some tools. Surgery, if we are talking about local treatment of lung metastasis and not systemic treatment. We have surgery and we have non-surgical approaches. In the field of non-surgical approaches, we have SBRT and we are ablative therapies. Among ablative therapies, there are some results regarding radiofrequency ablation and very few studies regarding cryoablation and microwave ablation in this specific group of patients. So in my opinion, we have these tools and we should perform our choice tailored to patients, because when, in my opinion, when surgery may reach a complete resection of this disease, I think that surgery, there is no evidence that surgery has a negative impact on prognosis. On the contrary, surgery may improve.
Yeah, so you think that the treatment will benefit in general those patients compared with natural history?
But there are some cases, since these patients tend to recur and tend to develop further lung metastases, and repeated surgical intervention may improve their lung function. I think that a non-surgical approach may be indicated. So the choice between different surgical approaches is related to number of lesions, their localization, the extent of disease in this.
No, I understand that choice, what treatment you do depends on many factors, but the fact that you treat those patients is, I think, the first question we have to ask, whether it's cost-effective and cost-effective in these times of what I said, sensible healthcare. But I think you answered this quite well, so I'll give the word back to the product.
Thank you.
Thank you, Professor van Zwam. Then the opposition will be continued by Professor Maria Pantaleo. She's a medical oncologist at Bologna University, Italy, and also she was a member of the Manuscript Assessment Committee. Professor Pantaleo.
Yes. First of all, thank you so much, and to be invited to be here. And first of all, I would like to make the congratulations to Cecilia Tetta for these large studies on lung metastasis from soft tissue sarcoma, because lung is the most important site for metastasis from this cancer. So my questions will focus on predictor factors, and in particular, you mentioned the primary tumor size and some histotypes. As you well said in the introduction, soft tissue sarcoma is a big family of disease, is not one cancer, is a big family of cancer with different histotypes. And what do you think about the histotypes who are negative prognostic factors for lung recurrence and also for specific mortality for lung metastases? And how do you think your data can be enlarged, or how do you think you can overcome this big heterogeneity of different histotypes in the family of soft tissue sarcoma?
Thank you, highly esteemed opponent, for these questions. Yes, in our results, some histotypes showed a higher risk of lung recurrence and specific death from lung metastasis from soft tissue sarcoma. Regarding lung recurrence, the histotype most affected this outcome was the malignant peripheral nerve sheath tumor. This is a rare subtype among a rare group of cancer, but our results were quite consistent with previous published evidence regarding this particular histotype, who revealed the importance of the malignant peripheral nerve sheath tumor, mostly related to survival. Our results show that it is a predictor of lung recurrence, and this, in my opinion, as far as I know, is a new outcome for this particular subtype, which is well known as being highly aggressive, also related to some genetic diseases such as the neurofibromatosis 1. According to the histotypes related to specific death from lung metastasis, synovial sarcoma is a well-known histology that affects survival, since it's one of the most aggressive and is one of the histotypes that more frequently develop metastasis. And it is also able to metastasize to lymph node. And this type, even though rare for soft tissue sarcoma, is considered a further negative prognostic factors for these histotypes. In our cohort, also myxofibrosarcoma showed a higher risk of death, but we related this outcome to the fact that in our cohort of patients with myxofibrosarcoma had larger primary tumor size. So we related these results to the larger tumor size. I hope I...
Yes, thank you.
Regarding your second question, so what can we do with these histotypes? Yes, it must be firstly highlighted that the soft tissue sarcoma are categorized according to their response to therapies. Yes. And this happens for chemotherapy and for radiotherapy too. In the field of chemotherapy, we have some subtypes that are response to chemotherapy. Chemosensitive. Other subtypes that are considered relatively chemosensitive, and others that are chemoresistant. So I think that now with systemic therapy, we may manage better, of course, chemosensitive subgroups. And there are some drugs related to histology in the field of chemotherapy. But the issue are chemoinsensitive, chemoresistant subtypes. And in these fields, I think that the novel therapies may improve the outcomes, such as target therapy, which is already employed for some subtypes. There are some targeted drugs that are employed for certain subtypes. So maybe research should, and I think it is happening, is investigating if the existing targeted drugs may be employed to other subtypes, and whether other targeted drugs that are most of them are inhibitors of growth or angiogenesis, may be applied to other histotypes. Even immunotherapy may be an option. And the interesting thing is that even for immunotherapy, a categorization of these tissues has been proposed according to their immunoresponse. And this thing, I think, is the first step to detect which histotypes may benefit from immunotherapy, which is a field, an ongoing field of exploration.
Yes, yes, correct. Just to correct, because you talk about chemotherapy, of course, which is the main, which remains the main treatment, systemic therapy for soft tissue sarcoma. But also you mentioned both target therapy and immunotherapy. And today we don't know which is the soft tissue sarcoma histotype that can be responsive to immunotherapy, because the studies are done in all soft tissue sarcoma and not specifically in each histotype. And do you think that in the future the combination of surgical treatments or not surgical, local treatments, surgical and not surgical, and the new systemic treatments, mix it also to the application of some of your predicted factors, can improve the outcomes of these patients?
Yes, I believe so. There are some evidence regarding non-surgical approaches associated with novel therapies that have shown that the combined therapy may improve survival. So I think, as I said before, that we must know the tools we have, and we may choose which is the best for patients according to their histology, of course.
Okay, thank you for me.
Thank you, Professor Pantaleo. Then we continue the opposition by Professor Cavalesco. He's a thoracic surgeon at Ferrara University, Italy. Also, he was a member of the Manuscript Assessment Committee, and if everything goes well, he may appear on the major screen, but you can see him.
Hi, good afternoon. I want to thank for the invitation to defend for this PhD segment, and I want to congratulate with the candidate for presentation of the thesis. It's real complete, a very wide excursion of a surgical procedure and other therapy. I have two questions. The first question is, which is the idea of the candidate about the surgical procedure, especially from open surgery to with-assisted surgery, which are the difference she thinks is in the different therapy. And the other question is if the candidate have some news about another kind of therapy. We used it a few years ago in our experience in the treatment of tissue sarcoma with metastases in the lung, and this kind of procedure is a stop-flow chemotherapy, local regional chemotherapy, following the surgery to treat the small metastases notified during the surgery. Thank you.
Thank you, Iris, for your question. May I kindly ask you to repeat the first question? Sorry, because I couldn't hear.
Your idea, which is your question about the surgery, when you think is necessary to do open surgery, or if enough in this kind of patient, the with-assisted surgery?
Yes, according to your first question, in our institution and in the field of lung metastasis, specifically in lung metastasis from soft tissue sarcoma, thoracotomy approach is preferred since it allows to perform a bimanual palpation of the lung and so to able to detect even very small nodules not detected by CT scan. However, with the last generation CT scanners, the sensitivity of CT has increased, and so we know better the extent of the disease when patients comes to surgery. In this view, I think that thoracoscopy may be implied with the advantage of being less invasive compared to surgery, and since these patients tend to recur and may undergo further surgical resection. However, the results are not so homogeneous in this field, so some researchers still believe that the best option is thoracotomy. Regarding your second question, the stop flow therapy, yes, this is one of the way to perform a local regional treatment by employing chemotherapy, avoiding reducing the systemic toxicity related to chemotherapy. And this technique has been implied, as far as I know, more for pelvic or abdominal advanced cancers, but there are some evidences of chemo stop flow therapy even in the lungs for primary and secondary tumors. There are few studies regarding lung metastases from soft tissue sarcoma, and they have been performed mostly on patients with an advanced stage of disease and with unresectable stage of disease. And it has shown to be a safe procedure with low severe complications, and I think it may be indicated in case of a locally advanced disease, preferably without metastasis in other site, because the high concentration of drugs that can be achieved through this treatment may improve local response.
Okay, thank you for listening.
Is the answer, and that means that we continue with the next opponent. Thank you, Professor Cavalesco. Dr. Vonken, he's an associate professor at the Institute of Department of Genetics and Cell Biology at this university. He was not a member of the assessment committee. No, we are sure members. The other people who oppose in the opposition are not members of the assessment committee. Okay. Dr. Vonken.
Yes, thank you, Mr. Projector. Congratulations on my behalf as well, and also to the team for what seems to be a very useful set of studies on the beginnings of introduction of systematics in this field, therapy, prognostics in STS. Super interesting. It's not my field at all. I'm not a surgeon. Well, I am a surgeon, a microsurgeon, but the only purpose that I use it for is to make little mice pregnant. So a completely different ball game. I'm happy you discussed you clarified the disease-free interval for me, because when I read the sentence in chapter 3, our analysis confirms that DFI influences LMR, and by the way, thank you for the abbreviation list. It had to me, that sat in the realm of the more birthdays you have, the longer you live. But of course, you did explain, and I'm very happy for that. You explained it to be a tumor intrinsic property rather than... Okay, so I'm a molecular geneticist. My background is pathways, models, that sort of thing. And this is what I'd like to talk to you about. It also relates to the question of, or one of the questions of Professor Panteleu. I missed the effect of chemotherapy in your models, in your thesis. Now, why is that?
Yes, thank you for question, esteemed opponent. You refer to the role of chemotherapy in this...
Well, the chemo that is being used, and I understand now why, I learned a lot, are big hammers. They're topo poisons or alkylating agents, and that's it. Even those may have an effect on lung metastases, the occurrence of lung metastases. But I had a hard time finding that back in your thesis.
Yes, the employment of chemotherapy in lung metastasis is debated, also because we investigated a group of patients in whom a complete surgical resection was achieved. So in this set of patients, chemotherapy is not uniformly considered as an option.
How is complete surgical resection defined? Is that an endpoint, an immediate endpoint, or?
In some articles, for us, it was an inclusion criteria. So we observed this through imaging, comparing CT, preparative CT, and follow-up CT scans. And we observed that there were no new nodules at postoperative CT scans.
And postoperative is how many days? How many hours?
Yes, there is an established follow-up for these patients.
Okay.
So we performed a preparative CT scan within 1 week before surgery.
Okay.
We compared, sorry.
The reason, no, thank you for that answer. The reason that I'm asking is that there was a recent publication about the Dutch Gynecological Oncology Audit Collaborator Group. It's a whole mouthful. Just a couple of months ago, that stated that they were looking for textbook outcome, basically meaning complete cytoreductive, successful cytoreductive surgery, right? And then the outcome obviously was the patient is cured for all intents and purposes. Turns out, pretty sobering message that half of the time, despite the fact that these self-reported success rates, we removed everything, 50% of the time, that appears not to be the case. And so that is a reason for concern. Now, I didn't know an awful lot about STS, so I did some reading up. And it turns out that quite a high percentage of STS actually has what is called a cancer stem cell phenotype. Now, that's super interesting for a molecular oncologist like myself. And for you, it's bad news. For the patients, even worse. Because this may explain a lot of behavior of these nasty tumors. Stem cells don't care much about chemotherapy. Stem cells, you can't recognize them. Stem cells push out tumors, and they're hiding somewhere else. So how does that fit in your models? You think you've removed...
No, of course we couldn't. Of course, our evidence are based on surgical samples with surgical margins, safe and negative margins, and on CT evidence. These are the methods we employed, of course. We didn't perform such analysis. No.
But do you see... And this is obviously where I'm getting at. We're getting better and better at defining what is wrong in a tumor. Yeah. And to put it academically, we're silly if we don't include those data.
Yeah.
right? So where do you see those type of features fit into your models?
Yes, I think this could be a further field of research, and it may be added as further information because, as you mentioned, it may be an explanation of on the fact that many patients, even with what we consider a complete surgical resection, tend to recur. And yes, it may depend on the biological behavior, on the aggressiveness of these cancers, but it may depend also on these insights, and maybe this could be investigated and had further information. I think we have not investigated this topic in this field.
All right, I'm satisfied. I give the word back to the Prorector.
Thank you, Dr. Vonken, for this fundamental discussion. Then we go to the following opponent, Professor Roberto Lorusso, cardiothoracic surgeon, specialized in ECMO at our institution, and he was also not a member of the assessment committee, so for him the book was also quite new when he received it. Professor Lorusso.
Thank you very much, Mr. Prorector, and let me first congratulate the candidate for the very nice thesis and what you actually included in, because I think you had several very important topics regarding also the daily clinical practice. And therefore, I have two questions. One is related to Chapter 2. The second will be on Chapter 3. But let's start with the Chapter 2. Although I want to say that I'm a little bit optimistic regarding the picture. I don't think it's a cigarette. Maybe it's something to use to write on the blackboard.
Ah, a piece of chalk, yes.
Let's be optimistic.
We'll keep it at that.
So, regarding the first question, you showed in Chapter 2 that the combination between the clinical details and the radiological features, this combination enhances the predictability of a tumor to be malignant versus non-malignant, regarding, of course, lung nodules. And you say that this combination will or is or changes the daily practice. How do you perceive this? I mean, how deep is the impact of this combination and this result, these findings regarding daily practice, and how it will be translated? Because then I would like to ask you if you have specific clinical features which are more important to be combined with the radiological features.
Thank you very much, highly esteemed opponent, for your nice words and for your questions. I am a radiologist. So the fact that clinical data and CT findings together may improve my everyday clinical practice is crucial for me, because it happens almost every day when we perform a CT scan to identify, especially in patients with a known primary tumor, to identify nodules, small nodules, even new nodules, round-shaped with well-defined margins. And yes, we know that a nodule with this appearance may be malignant. This is a well-known fact. But it may be benign too. So it's important to strengthen our suspicion, and this may be strengthened by the integration with clinical data. And this is the first thing. But the most important thing arises when we detect an atypical nodule. And it happens to detect a very small nodule, probably new, with an atypical shape, an irregular shape, with ill-defined margins, speculated or with some cavitation. And this is an issue in these cases. So in my personal experience, knowing clinical data of these patients may help me to address these patients as soon as possible to a surgical consultation, to an oncologist consultation, to address which is the best future step, if a closer follow-up, or if these patterns are diffuse, to consider surgery or other treatments. So, in my opinion, this has a significant impact on my...
That's fine, absolutely, I understand, but are there specific clinical features that you consider more important than others? Because here you, of course, listed quite a very long list of clinical features, but do you think that specifically some of them are crucial to combine with radiology?
Yes, it's important to know the grade of these tumors because it has an high impact, and the surgical margins has shown to be an important prognostic clinical factors in these patients, keeping in mind that to achieve this information required surgical. When I encounter an atypical nodule, and if I know by clinical records or asking to my colleagues that there are other factors of risk, such as a positive surgical margin or an high grade, or moreover, if the subtype is a synovial sarcoma, I must be very careful.
This means that the trend that we see now more and more for a remote radiological consultation would be not really the ideal environment for such. What do you think about that? I mean, your statement, your conclusion seems to say, well, look, the radiologist and the clinician and the surgeon must work really in close contact. So this is a little bit in contrast with the trend that we see more and more.
Yeah.
Is that right, or?
I am lucky because in our institute, soft tissue and bone sarcoma patients have a well-defined pathway. So, as I said before, they have scheduled appointments, and in that day they have CT scan and professional reports. I know this is not a rule. I'm well aware of this, and I think that this doesn't have to be underestimated, because in my opinion, beyond all the prognostic factors that we explored, there is one thing that is very important: the delay in diagnosis for these patients, and it happens more often than we may think, since if these patients are referred to a not tertiary center, these masses may be confounded with hematomas or other conditions, and the delay in diagnosis in such aggressive sarcomas is crucial because they develop fast and they tend to metastatize very quickly in some cases. So it's crucial for me.
Thank you very much. And then very short second question regarding chapter 3. You mentioned and you clearly show in your presentation that the DFI, so the disease-free interval, is very important because it gives you some prediction regarding, of course, the severity of so the shorter, the more severe is the tumor. But how is this also, this disease-free interval, going to, again, impact how you can use this information in your clinical practice?
Yes, the disease-free interval is a well-known prognostic factor, as I said, both for lung metastasis and for survival. And regarding disease-free interval, many cutoffs have been proposed in literature, beyond which the risk is lower, of course. Our results, especially related to lung recurrences, showed that there is not a cutoff of disease-free interval, because our analysis displayed that we had the highest risk of recurrence with a DFI ranging from 0 to 18 months. But after the 18th months, the risk didn't decrease quickly, but slowly, and remaining significant up to 78 months after lung resection. And this data is crucial to define follow-up in these patients, because we know that after 5 years of follow-up, these patients usually undergo one visit a year. So if there is a lung recurrence, I think that follow-up should remain stricter.
Thank you very much. I'm satisfied, and I give the word back to Mr. Prorector.
Thank you, Professor Rousseau. Then the opposition will be contained by Professor Lameyer. He's cardiothoracic surgeon at from Belgium, Free University of Brussels. Professor Lameyer.
Thank you, Mr. Prorector. It's my turn now to congratulate the candidate. I have to admit, your last slide was for me, in fact, really the conclusion of your thesis, because you stressed the multidisciplinary team. And in fact, what you did in your thesis is a multidisciplinary approach to the pathology. It's not only about radiology, it's really the multidisciplinary approach. And I think the corona is in fact representing that. It's not radiologists who are present, but really the multidisciplinary approach. So congratulations for that, but I believe that that is very important, certainly in treatment of cancer. So I also have some questions, and I would like to thank the other opponents that they left me the time for my questions. So my first question was, but I will still want to tell, because it's an interesting thing in your chapter 3. In fact, the title, there is a mistake in the title. We talk about metastatectomy.
Oh, sorry.
And yeah, but I'm impressed because we read it. I mean, the reviewers read it. It was published. I mean, you created a new word. It's like Shakespeare. Right? So some people create new words, but I've tried to find a good meaning for it, but I cannot find a good meaning. But for you, would there be another meaning for that word, or do you just take it as a mistake and we just leave it like it is?
Thank you very much for your punctual observation. Highly esteemed opponent, of course, is a printing error and is not a new entity to investigate. I noticed this, but it was late. So I didn't have the time to correct all the copies. No, sorry.
But perhaps the task for the oncologist is to find a new sense in this word, because it is something we could use, pulmonary metastasis, I don't know.
But however, the word metastasectomy is so stressed in this thesis that I mean that
no, but that's why, maybe that's why everybody overread it, I think. That's why, because you read what you see or what you want to see. Let's say, continuing with chapter 3. In your limitations, you clearly state that it's a long period, 30 years of follow-up, right, in the total, let's say, thesis. Yeah. And therefore you write yourself that there are different techniques available, different solutions available concerning surgery. I'm a surgeon. Would you think that the outcome would have changed because there are not too many metastatectomies done by thoracoscopic approach? They are mainly done by a thoracotomy. And thoracoscopy perhaps would have improved the outcome because of better visualization. The view is certainly improved by use of camera, use of robotics. Do you think that could have had an impact on your outcome?
Maybe. I think that the choice of the best surgical approach relies also on professional local expertise. And in our institute, we have a deep expertise in the field of thoracotomy, and our surgeons have a great attitude with this method. Thoracoscopy, as I said before, is debated. The main indication to thoracotomy is related to the clinical status of this patient, to the clinical consideration, they tend to recur. But in my opinion, thoracotomy may allow to better detect, as I said, small nodules, since the resection of all nodules detectable is crucial for these patients, is one of the most prognostic factors of lung recurrence, and it is well displayed in many published articles. So it's a crucial point, and I think that thoracoscopy may be an option in selected patients. I believe this.
Thank you. One last question then. I would like, is there a panel who can read proposition 10?
Having discovered the existence of of course. Having discovered the existence of a new kind of race.
That indeed you have no chance to perform. Dear candidate, the time for your defense has passed away. Has not passed away, is over now. The committee will withdraw, and I ask you and your company to wait for our arrival here, and we'll come back with our verdict.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side. 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. On the line, I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile. Long road to the south side, 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Hit the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. And even though these nights seem long, I know that I am never on my own. Know you've won the battle once you've grown. South side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. fly by now, don't waste all your time. 'Cause I'll go the extra mile.
Dear candidate, the committee has discussed the quality of your thesis and the way you have performed this. And based on its positive verdict on both, and in view of the previous academic examinations you passed, it has decided to grant you the doctor's title. Professor Gelsomino is authorized to confer upon you this academic distinction. He gets his last instructions now, and then the floor is to your promoter. Oh, wait, you do not have every paper, what you need? You have to wait a moment, there is still some official paper to be brought. Is that true? The promise he makes, okay. You have first to make a promise and then you get your title. Okay. And the paper of that promise in English is being brought in now. Professor Gelsomino is still waiting for that.
This suspense is scaring me, no?
It has to come from the office. It was not. Ah, there he is. Please rise.
Cecilia Tetta, do you promise to work in accordance with the principle of scientific integrity at all times, to be careful and honest, transparent, independent and responsible?
Yes, I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Cecilia Tetta, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university.
Will be spoken by Dr. Rocca, one of the supervisors.
Okay, well done. It's a great honor for me and to be here, and it's also a joy to witness such a prestigious milestone you have achieved today. I have known you for many years, and I have had the opportunity to admire the great physician, the undeniable and rare talent which, coupled with your dedication to your work, has made you more than just a renowned radiologist. You have become an absolute reference in the field of musculoskeletal radiology, a reputation that I have personally observed extends far beyond the medical community of our region. I have had the privilege to admire the excellent colleague devoted to her work, always kind, helpful, collaborative, open to constructive dialogue, and consistently professional with her colleagues. You have always been willing to lend a helping hand in times of difficulty, always putting the patient's best interests first. I have had the opportunity to appreciate the outstanding educator who over the years has wholeheartedly trained dozens of young colleagues. You have never been authoritarian, but always authoritative, with the sole purpose of passing on your knowledge to young radiologists. I have witnessed the immense gratitude, respect, and affection that these young doctors still hold for you even years later. Some of them still reach out to you for clinical advice, and like a good teacher, you are always there to respond, never positioning yourself as a master. I have had the great pleasure of getting to know the person, a woman of character, yet always elegant and polite, someone who never raises her voice but makes herself heard very clearly. You are intellectually honest and transparent, with unwavering integrity, yet at the same time very flexible and open to the exchange of ideas, fiercely witty when necessary. During these years, we have worked together to reach this milestone. I have discovered the side of Cecilia that I didn't know, the researcher. Beyond the outstanding qualities I was already familiar with, I discovered and admired your ability to immediately identify the research questions and direct your analysis toward attempting to answer these questions. However, what truly sets apart a skilled clinical researcher from an average one is the capacity to translate research findings into clinical message that can be applied at the patient's bedside, and you have done this excellently. Assisted by exceptional intuition and vast clinical experience, you have completed the picture of Dr. Cecilia. Research broadens a physician's horizons, making their mind more flexible and refined. It makes them better equipped to handle complex situations and identify the best options for their patients. You have grasped the profound essence of the research, never viewing it as an end. You began this journey as a diligent student, almost unbelieving and inexplicably uncertain about your aptitude for research. Today, you conclude it is a distinguished expert. That's why I wish for this day and this significant milestone to serve as a stimulus for you to continue your research endeavors. I believe that the scientific community needs individuals like you to propel ambitious research projects and nurture the development of new skilled researchers. A brief mention of your courage is in order. I'll be concise because I understand this is a sensitive topic. Choosing soft tissue sarcomas as the subject of your PhD under the circumstances you faced is not a decision made by everyone. It instills in me a profound sense of admiration, and I leave it at that. Today is a day of celebration, so let's cast aside sorrow, embrace the satisfaction wholeheartedly, revel the achievement, and cherish this very important day. This supervisor, speaking on behalf of the other supervisors, wants to convey that it has been a pleasure and a great honor to work with you. Well done.
Dear Dr. Tetta, it is also a pleasure for me to congratulate you with this new title, newly grasped title, and confer this also, bring that also to your possible relatives who are here or on the screen somewhere at home. You are not an alumnus of this university, and then it's always a big pleasure for us to have somebody from another university to finalize here her academic education, because that's what we consider this title, the end of an academic education. Very often we say there's also the beginning of a good career, but for you that is no problem. I don't have to wish you a good career because you are already in the middle of it. Congratulations. And thank you for choosing our university to get your title.
It's an honor.
For always your name will be connected to this university from now on. You are not aware of that, but that is the fact of life. And thank you for that. I thank also our guests from other universities, Professor Cavalesco, Professor Lameyer, and Professor Pantaleo, for the honor they have given us to do their jobs at our university. You will ask yourself, why do you not mention the others? But there are people who work here and who have to do that. That is their job. They get paid for that and don't need special thanks. That is their daily work. Having said this, some practical points. It is always nice to have a picture of the ceremony. We will make one official picture in the hall, in the staircase. That's for your office at home. And I've noticed there is somebody taking pictures. Could you do that also? Yeah. And in that case, we do not go out in a big procession, which we normally do, and followed by the audience. But now we stay here, make here a circle of the corona, as we call it. That's we. You in front with your diploma, Professor Cavalesco on the background on the screen, and then you have that on picture. After that, the session has then been closed. We have to leave here. Professor Cavalesco will be turned away. He disappears in the cloud or wherever. We don't see him anymore, and we go to the hall for the official picture on the staircase. Okay? Then I close this academic session.